Thank you to Celia and Emily for putting this together. I think many of you were at a meeting we held back in June 2018 to really start anticipating actually a lot of work that many of you are already doing in terms of understanding how we can use these new G6PD tools to improve medical cure and management of vivax. This is actually very exciting. This is the kickoff of what we hope will be a platform, this community of practice for sharing resources across different groups doing work in this area. And the intent of this platform is by no means to make people think the same way or try to do the same things, but actually for it to be a sharing forum and an opportunity for people to adopt things that are working and learn from lessons learned that other people are experiencing. And in that way, hopefully iteratively, we can all improve what we're doing and answer the questions we're trying to ask. And I think the important thing is the workshop that we held back in June really focused very deliberately on the premise that if we want to offer best clinical practices or tests for G6PD deficiency before administering primaquine, and we will have to do that to make tafenoquine available, we don't want to just put a G6PD test at the facility. We want to make sure that it's been, A, when it gets there, it's in good condition, B, it's actually run correctly, and C, that the results are interpreted correctly. And then after that, the interpreted results are actually used to provide the right treatment decisions. And there's quite a lot of steps there, and I think we're all trying to reassure ourselves that can be done. And so how do we do that is what we want to get at. So welcome everybody. I hope, we'll be seeing more in terms of a platform in terms of where we will be putting resources that different partners are willing to share. We will definitely be sharing our protocols and our materials on that, and you'll be notified, and we'll talk a little bit more about that. Also, sorry. Yeah, so also, I do want to thank Jose, Diego, David, and Marcus and Walton from FMT and HVD in Brazil, and then Marius Jornowski. Sorry, I don't think I've pronounced your name properly. From AFRIMS in Thailand, who are going to be sharing some materials and experiences they've had with actually trying to implement the CareScout RDT. And then Emily's also going to be presenting some of the thinking we're putting in as we prepare to kick off some studies as well. And with that, I'll hand it off to Emily.
Thanks, Gonzalo. Can everyone hear me okay?
Yes.
Great.
Yes.
Yes.
Great. So good morning and good evening, and thanks again for joining us. As Gonzalo said, we really hope that this becomes a sort of regular platform that we can all use to share progress and updates. And I wanted to use this first opportunity to really focus on training end users on the use of the G6PD tests. And so that's what Jose and Marius will spend the time today talking about. But before they do, I thought I would just provide a brief overview of how PATH and others that we work with in this space have been thinking about G6PD usability testing and user considerations. Because while we are moving into the field, transitioning to the operation of these tools, we've been thinking about these issues and trying to understand them better and talking about them with end users for a lot longer than that. Celia, if you could move to the next slide. So I think, just starting with the sort of core understanding that we know end user training is going to be a really critical component of G6PD testing and introduction at scale. We know that point of care G6PD testing is more complex than traditional malaria RDTs, and their use in the places that we're talking about, where the vast majority of care seeking happens, is going to challenge those systems in some ways. There's been limited rollout of G6PD testing outside of research settings, but we know that evidence on how this is going to work is critically important to the country programs that are going to adopt these tests. So when we talk to key stakeholders, when we talk to laboratory and clinic supervisors, that's always sort of at the forefront of their minds, and so it should be also at the forefront of ours. And the research community has done a significant amount of work to understand and try to anticipate some of these user issues. And I've just outlined a few of them here. So PATH and others have conducted user research through sort of formative, observational, contextual inquiry, summative and evaluative usability testing in a number of geographies across multiple products. A lot actually done in collaboration with SMRU in Thailand, and really looking to understand the products and understand trade-offs between them. And then also through years of engagement with key stakeholders, so meetings with NMCPs and others to introduce the concept of the products and how they will work. And we've looked both at the user considerations for the product itself and then also for integration into the context. And we know that the integration into the case management is going to look very different depending on where you are. So you may be in a place where malaria slides are made by one person and driven to a health center to be read by a microscopist. You may be in a clinic where venous blood draw is done to test for a number of different pathogens, and people are less comfortable with finger sticks. And in general, you're probably working in a place that's remote and far from a centralized laboratory or supervision where quality control procedures that are common to those labs can be put into place. Our more focused usability testing of the products themselves have a few common usability issues have emerged from this testing. And so this is sort of looking again through the lens of individual users. For one, we know that these tests require very small and precise sample volumes. We know that results interpretation, as Gonzalo talked about, is a complex and multi-step process, particularly with regards to the quantitative tests. So, each of those steps, from recording the result to interpreting the result to potentially sharing the result with somebody who needs to use it to make a treatment decision, is really important. And this is in relation to not just the quantitative test, but the qualitative test also, where we know that results interpretation is a little bit different than the traditional format. but one of the encouraging things that I think has come out of all of this user research is that the learnability of these tests is high, and we've seen with a range of different health workers working across the spectrum that they have a demonstrated ability to run the test successfully when they're sort of given the tools to succeed and they have sufficient time for practice. Celia, if you could move to the next slide. Great. So on this slide, I just wanted to outline some of what I thought were the key implications of these user research findings for G6PD testing rollout. Excuse me, 1 second. To start, assessing and monitoring user proficiency is challenging due to the lack of control materials. So there are limited availability of commercial controls that work across these tests and across platforms. And so it kind of challenges the way that we might traditionally think about decentralized quality assurance and quality control procedures. And I think people have begun to think really creatively about this problem and really come up with some innovative ways that work in their settings. And I think the more we can share those solutions and continue to update on how that's working, that'll be really useful. Particularly any sort of normative guidance around what that user proficiency should look like, I think will be really valuable to start to document, you know, what specific requirements are different settings requiring before users use the test in the field. Again, another implication is just this variation across contexts and how the test will be used. It's going to be different, and there also might be multiple users within the context, sort of within that patient flow. So the person running the test might be different than the person who is interpreting the result and making a treatment decision. And I think our training has to address both components. I think particularly in places with a lower caseload, the users may run the test infrequently and therefore be missing opportunities or threatening opportunities to learn over time. And I think we need to make sure that resources are in place that anticipate that someone might only be running a test, you know, once or twice a month rather than every day as part of their job. The next implication here that I included is just that G6PD testing and G6PD efficiency in general is a relatively complex concept, and I think we haven't quite nailed down exactly what information about the condition and about the biological mechanism needs to be conveyed to users in order for them to conduct testing effectively. So based on their level of training, their level of education, different messages about this might be necessary. And I think the operational research work that we're about to start, I think will help us hone those messages and really understand what someone needs to know about G6PD in order to run the test correctly. And then particularly in regards to quantitative testing, you know, the results interpretation is multi-step, and there's still a need for guidance on how that will be operationalized, you know, between sites and between countries. So that was just a quick brainstorm for me on some of the potential user issues as we think about training. And then I'll hand it over to Jose from FMT to talk about their experience actually doing this training with one of the G6PD products.
Hi, can you hear me?
Yeah.
Yes, yes.
Yes.
Okay, fine. Nice to meet you all. I'm Diego. I'm here in Manaus with Dr. Welton and Marcelo. And today we are going to discuss some steps used in the training for the SAFEPRIM study, which is the implementation of the CareStart rapid diagnostic test in 2 Vagos malaria endemic municipalities here in the Brazilian Amazon. Next slide, please. Good. So the main goal of the project is to evaluate the implementation of the CareStart in these 2 Vagos malaria endemic municipalities of the Brazilian Amazon. By evaluate the implementation, we mean to verify some operational aspects of this implementation, going from the personnel training, the health workers training, from reliability analysis, and also acceptability analysis from these health work agents, so that we can have the feedback about the usability of the RDT in the field. So this study will be carried out in 2 municipalities. The first one is Rio Preto da Eva, which is somewhat close to Manaus, around 50 kilometers, I'd say. And the other municipality is Mancio Lima in the state of Acre. The state of Acre, it's a bordering state between Brazil and Peru, and it's one of the most, it's one of the municipalities that most report cases in Brazil nowadays. Next, please. So this is the diagram that represents what will happen in this implementation study. We have these 2 municipalities, as you can see, and the study will be conducted on healthcare workers that work at malaria diagnostic units in these municipalities. All the malaria diagnostic units will be accessed in both municipalities. So before the implementation of the G6PD RDT itself, we had obviously to train these health workers and agents to perform and also to interpret the results of this G6PD RDT. And after we had a reliability analysis, which means after the training, if they had a reliable diagnosis based on the change in the color and the platform. After a good result on this reliability analysis, then the test will be implemented in the field. And after a specific period of time, 1 month, 6 months, and at the 12th month, we would perform reliability analysis to check the knowledge of these trained health workers, and also acceptability analysis, which is carried through a semi-structured interviews to verify the view of that health worker towards the implementation and the benefits of this rapid diagnostic tests. Next, please. The other part of the study is also the user satisfaction assessment. Through semi-structured interview, we also assess the satisfaction of the health user towards the benefits of the implementation of the rapid diagnostic test in those municipalities. We also perform quality control analysis on the test performance in the field, also the G6PD prevalence analysis, and we also implemented a blood smear for malaria on D5 to help strengthen the pharmacovigilance system in those cases where the test did not identify well, especially females in these municipalities. So all patients undergo the test on the day of the malaria diagnosis, and on the 5th day, these patients have to return to that diagnosing unit to verify and identify possible symptoms of acute hemolytic anemia, and also to assess chloroquine resistance in this patient. So if a patient comes to that diagnosing unit with signs, with classical signs of hemolysis, then this patient is referred to a reference institution for a proper clinical management. Next, please. So this diagram sums up what will happen in these two municipalities. The implementation period takes 12 months, which is followed or preceded by a pharmacovigilance period before or after the implementation of the tests, so that we can compare between the two municipalities if a decrease in the rate of hospitalizations took place before, and if the implementation of the test really had an impact on that municipality. And on the first and 6th and 12th month, we will also perform reliability analysis, quality control analysis, and also semi-structured interviews to assess acceptability analysis. Okay, next slide, please. Now, focusing on the training of this personnel. In the SAFEPRIM project, we trained all agents that worked directly with malaria or other agents, the community agents that may work with malaria during an outbreak, for example. So we split this training in two parts. The first part encompassed all agents. On the first municipality, it was around 140 agents. So we gathered them in one big room, and then we had a set of training slides. In these slides, we talked about malaria, about treatment, in order to refresh about the clinical spectrum of disease, and also the different treatments. And at the end of this theoretical part, we had a supervised practice. In this supervised practice, these agents were able to get used to the test platform, and also to perform the finger prick blood collection, and also to access and interpret these results. And then we took all these agents and divided in small groups of 10, and for each group we had one monitor that would oversee the activities and the performance of these agents. So this was made in one day, and in a future time we would evaluate how these trained health workers would access the results using the platform. So we had like a panel of 10 tests. In this test, we had a negative, a normal result, a deficient, and an intermediate result. And we only considered that that agent would be able to perform correctly a test if they had a minimum 90% score on this panel of 10 tests. So in the case of a health worker that had less than 90%, we would perform a recycling review with that agent, and he would have the same opportunity to take this evaluation with a different set, a different order of results. Next, please. So on the first part, which was the theoretical and practical training, we had used some job aids, which are recommended by the guide from the World Health Organization for the training on G6PD RDTs used. So we had this folder, which is the size of a standard paper that we would hand to all health workers that attended the training on that day. So this folder in particular was for them to keep to themselves. And I apologize because it's not an English version, it's a Portuguese version. But in this folder, we would explain what is a rapid diagnostic test, when it must be used, how it works, how to store, how to transport, and some laboratory safety practices that should be used when performing these tests. And also you can see that there is the algorithm of decision after the results. when a patient with a normal result would take the standard Primaquine for 7 days, and the other patient that is not apt for the use of Primaquine, the cases of deficient and intermediate results, would take weekly supervised Primaquine. Next, please. This is a continuation of the folder that is given to these agents. You can see that it's also showing how to perform the test and also how to interpret the test. When there is the color, the patient is apt for the use of Primaquine, and where there is no color or little to no change in the color, that patient is inapt for the use of Primaquine or for daily Primaquine. And we also had the invalid result when some error may have happened during the performance, and that those cases the agent should repeat the test. Next, please. And the second material was something that they really liked, especially because they like a lot this. They try to be always visual, something that they can keep with them on the malaria diagnosis unit. So we created this post that sums up what is explained in the folder that was handed to them. But the difference between the poster and the folder is that the poster is pinned on the wall of every malaria diagnosis unit. So they are all the time in contact. If they have any questions regarding the procedure and the algorithm of decision, they can check really quickly just by looking at the wall at the moment of the malaria diagnosis, and then can have their questions answered. Okay, next slide. Oh, I forgot to mention too that during the theoretical training, we also developed a short video around 2 minutes, 2 to 3 minutes, where we show how to perform this test from the finger prick blood collection to disposal of the materials used in that procedure. So we could also share this video with them, since most of them use WhatsApp, so they can share and circulate this video in case they have any questions and need assistance while performing the test. So in the theoretical part, in the set of slides used in the training, we had a little introduction about malaria treatment and other things. And we also talked about how to use and how to perform all the steps from the rapid diagnostic test in the field, including how to identify possible signs of hemolysis and patient counseling, and also for the active surveillance of clinical symptoms of acute hemolytic anemia. At the end of this training, we had a Q&A section where they could ask possible operational questions regarding to the implementation of this rapid diagnostic test. And at the end of the theoretical practice, we also had a small quiz where we would access some things that were given and were taught during the training. For example, what's the treatment for a patient that cannot take the Primaquine? What's the result of this test shown? What are the possible signs of hemolysis? And so on. And to make sure that they are correctly performing this test, we also have field supervisors. These field supervisors are responsible for overseeing the implementation of the test in the field. So they have direct contact with the health workers to answer any questions and to make the bridge between the field and the research team we have here at FMT, or the Tropical Medicine Foundation. Next, I think this is the last one, right? Yes, good. Okay, so that's pretty much what happened so far with the SAFEPRIM study, especially with the training of the health work agents. Thank you.
Thank you, Diego. Marius, we've got your slides on deck, and we'll have time for questions after your presentation.
Sounds good. So can you hear me?
Yep.
Okay, perfect. So one of the challenges when I was trying to, decide which slides to show was trying to figure out what I can focus on in the next 10 minutes. So in any case, again, I'll try to maybe get some key messages across of what we did in our study, where we're heading next. And then if there are questions, again, I'm happy to fill in the gaps if we can get to it in the next 10 minutes with the question and answer session. And in terms of some of the materials, again, I'm happy to share those as well. Next slide. And again, this is a standard disclaimer. I know it says government property. I basically use a standard disclaimer, but all the slides that I've sent to you can be shared with any of the participants of this group. It's not a problem. And again, I think with the focus of making sure we share information, learn from each other, we're also going to be happy to provide some of the materials that we've used in our study. So this is just a standard disclaimer I have to still disclose. But within this group, it's perfectly fine to share the materials. Next slide. So the reason we did this study was knowing that in Cambodia, they're trying to deploy Primaquine, and we had multiple discussions with National Malaria Program, and the challenges have been that despite multiple discussions, there was not a clear way forward how we're going to deploy Primaquine treatment. And also in terms of there were no proven strategies for training the providers on some of the limitations that we do know exist already. I think with there's a lot of research that has already gone into these testing, not only the rapid diagnostic test, but now with the biosensors. I think we've learned a lot. We understand the limitations of these tests, but we also understand the benefits. But how do we convey those messages to the healthcare providers, and how do we make sure that they understand the limitations and benefits and the appropriate balance? We also try to gather a bit of more information about the community perceptions about Primaquine. What are their perceptions about the risks and benefits in the community at baseline before deployment of these tests, and also after the training that we provided, we were reassessing them over time, trying to see how the perceptions may change over time. And our focus was on novice users, so providing training among those healthcare staff who have limited prior experience with Primaquine testing or G6PD screening. And again, there have been not that many studies that specifically focused on the community level of understanding about these different G6PD diagnostic tests and the risks and benefits. And our ultimate goal is really trying to focus on deployment of tafenoquine. Personally, I think tafenoquine is where we need to aim in terms of radical cure. But I think one of the messages I'm going to try to get across through these slides is that before we can get to tafenoquine radical cure, we will need to ensure that these diagnostic tests can be safely deployed with Primaquine. And so it's more of a gradual process of transitioning for making tafenoquine available. Next slide. So the bottom of the slide is cut off a little bit, but basically this gives a general picture of how we designed the study, which is similar in scope of what was just presented. But in general, we had the healthcare workers, we have village malaria workers. And the reason we included village malaria workers is because we wanted to see to what level of peripheral healthcare can we actually deploy these diagnostic tests. So we had some nurses, we had some providers from the health centers, but primarily we wanted to include village malaria workers because we did know that they're going to have the lowest level of education. If we can show that this training can work at that setting at the level of village malaria worker, then we would be more comfortable saying that, well, this should be deployable at a higher level of care. So everybody completed pre-training questionnaire as we tried to understand their perceptions about risks prior to training. and also their prior baseline knowledge about Primaquine and the G6PD screening test. And similarly to what was presented, we had training which was theoretical training focused on the G6PD screening. Who needs testing with G6PD screening? What are the limitations of the testing? We talked a lot about how environmental factors can affect the test results. What are some of the challenges with visual interpretation of the color? We had extensive discussions also in terms of why we are focusing on male patients and why we're not using the rapid diagnostic test for screening female patients. And then, so one aspect of the training was focusing on the G6PD tests themselves, and then the other training slides were focused on focusing on the drug treatment. So making sure that they understand the risks and benefits, what are the symptoms of hemolysis, what are the different dosing regimens of Primaquine, whether you have FALCIPRIM or Vivax, why you need to have different dosing regimens. And for some of this, we used a standardized counseling script that was developed for this study. So besides having a presentation, a PowerPoint, and a question and answer session, we then continued with a hands-on practical training where we basically had all the trainees practice on the rapid diagnostic test, and we actually incorporated use of control samples. So we purchased G6PD normal samples and G6PD deficient and intermediate, trying to get a general sense of how they interpret a test at a more controlled setting at the workshop before we basically allowed them to test volunteers in the field. And the general feedback was that was very useful component of the training, because in general trainees felt much more comfortable with using these tests following this workshop training with some hands-on practice. And then in terms of the field testing, so we had 3 different levels of testing. So we had G6PD reading by the trainee in the field setting. And then we had a reading with a second RDT, which was done by an expert reader, but also in the field setting. In other words, we tried to decipher a little bit better whether there could have been an issue with the training itself or the environmental conditions. So in other words, if we saw a difference between an expert in the field and a trainee in the field, that would have pointed us towards more of a problem with the training versus the field issue. And then we also had rapid diagnostic testing done in the central laboratory. And in addition to that, the same samples from the same patients were also tested for quantitative testing, and we used Trinity quantitative testing methods for validation of the results. And again, all this testing was done blinded. So the trainees did not see the results of the expert reader in the field, and also all the RDT results were locked before the results of the quantitative testing were revealed. And in terms of, next slide. So again, the objective was trying to develop training materials to improve the knowledge and acceptability for the screening and Primaquine use, but also, again, assess the performance of this rapid diagnostic test among the healthcare workers and village mobile workers in the field settings. So again, we started with the workshop training, which was 2-day training, and then we proceeded in the field testing with using these tests. Next slide. So in terms of some of the tools that we utilized during the training and evaluation, so we had pre and post questionnaires. And the purpose of the questionnaires was trying to, again, assess the knowledge about G6PD testing, perceptions of risk, And the idea was we wanted to pilot some of the questions, thinking that maybe down the line it would be worthwhile to consider some certification of competency. So I think the WHO currently has competency evaluations and certifications for microscopists. So the question that we want to pose to this group and for discussion is, should there be some sort of certification of competency, and how would that how would that look like in terms of what questions we want to ask, how many questions? I don't think that's well defined, but I think with some of these studies that are now being deployed and implemented, I think with sharing some of these questions that are being used in the field, we may be able to select some set of questions that would be suitable for future certifications of some sort. And again, we did use a standardized counseling script. The one lesson, and that's what you see on the right side, you know, the counseling script, it was several pages long. And again, the challenges we had as we were designing a counseling script, how much information to put in there so it's complete, but at the same time, how do we make the counseling script short enough so it's not overwhelming, both to the trainees, but also to the patients and volunteers. The one thing we learned with deploying the counseling script, so we had a text that was written for each of the graphics, just to make sure that our initial idea was that the trainees would actually read the text and then they would engage in a question and answer based on each paragraph and each picture. But as we went to the field, it was very apparent that all the trainees were heavily reliant on the graphics themselves. They were covering a lot of what was in the text, but they were paraphrasing what was in the text. So I think our next generation counseling script would be more heavily on the graphics and much less heavy on the text, just because again, from the feedback we received, the idea was to standardize it, but the text is still going to be paraphrased. So I think we do need to make sure that we have very good graphics to get the key messages across in order to make sure that the counseling is effective. Before we go to the next slide, so in terms of, I don't think I have the sample size here in this few slides. So we actually did this counseling for 1,500 volunteers in the field, and we had a total of around 100 trainees. So each trainee tested up to 16 adult male volunteers in the field. And again, we were evaluating them and their knowledge over time, and also their perceptions, if they changed over time. Because one of the questions we posed to ourselves in this study, will the trainees become more comfortable with using these tests over time, or will there be any changes in how they perceive these diagnostic tests? Potentially to the negative as well, because if there were problems with how to read the color, there were some questions whether over time maybe the willingness to use these tests would actually decrease. So those were some of the things we were asking, trying to collect through this study. Next slide. So again, this is just some of the graphics we used. There were many more, but I'm just giving you an example of what we used in the counseling script. So the graphic on the top left, again, we try to convey to them that there's a difference between SAFEPRIM malaria and Vivax malaria, that there's a difference in how much Primaquine tablets you have to take for how many days. Then on the right side, again, we try to communicate to them that when they take Primaquine for SAFEPRIM, it's for a different reason. It's for a community benefit, for blocking transmission of malaria, versus for Vivax, when they take Primaquine for Vivax, at the bottom left corner picture, again, we try to convey to them that in order to eliminate malaria from the liver, they need to take Primaquine for treatment. Otherwise the malaria just keeps coming back. And general feedback was that these graphics were very easy to understand and well received. Then we tried to also have pictures and graphics for making sure that patients know what to look for when they get discharged with primaquine, in terms of what are some of the side effects they may experience, and especially what are some of the symptoms of hemolysis. So again, we had the fatigue, back pain, dizziness, yellowing of the skin and eyes. And the general feedback on this particular graphic was that it was very confusing still to both the trainees and the patients. One of the main questions was, well, what if I just have dizziness, but I don't have breathlessness and I don't have the fatigue? Should I be worried that I may be experiencing hemolysis? How many of these different factors do I need to have before I should worry that a patient has hemolysis, and we would get the same feedback from the patients themselves? Well, so I think that's one area that needs additional exploration in terms of how we develop this for the next version of our counseling script. How do we communicate the symptoms that patients and trainees need to know in terms of hemolysis? Next slide. So these are the results, and I'm showing these results for two reasons. One main reason is because as we did this study, again, we were thinking from the perspective, the next stage is going to be biosensors and deployment of quantitative tests. So some of the things that we're struggling with now, also with our trainees, is because for male patients, the WHO guidance says that 30% is the threshold for defining normal versus deficient. We do know that from the populations and the studies we've done that there's going to be patients who are going to fall somewhere between the 30 and 40%, or even right over 40%. And it's going to be much more critical for the quantitative testing in terms of training, how people interpret the thresholds, because we need to decide whether we're going to stick with the 30% or not. And the complexity is going to be that the threshold for tafenoquine use is different than for calling males normal versus deficient by the WHO guidelines. So again, how do we communicate these messages? I think we understand what it all means, but how do we communicate these messages at the peripheral health center levels to make sure that this is not confusing down the line? Okay, next slide. So what I'm trying to show here is basically in terms of the results from this study. So again, we had close to 1,600 volunteers who were tested in the field, and you see the sensitivity of the test on the bottom. So anywhere between 95.6% to 97%, and there was no statistical difference between these three. And again, the differences are whether the RDT was done by the trainee, whether it was done in the field or by the expert in the lab. And then you also see the specificity as well. So there was actually statistical significance in the specificity of the test results. So the reason there was difference in specificity is explained, I think, by the top figure, where I'm showing you how many we had deficient based on the validated quantitative test, which was 251 patients were deficient with less, based on the 30% cutoff threshold. But as you can see, the trainees were more likely to call call deficiency when there was no deficiency. So they were overcalling deficiency more compared to experts in the lab. So experts in the lab they basically only overcalled 2 patients for deficiency. So they were much more, so they were better in making sure that they don't overcall patients with deficiency. However, that did result in slightly higher number of missed G6PD deficients who are called normal. However, that difference was not statistically different among the groups. So that's something to. So I think the takeaway message from this is that there will be patients who are going to be misclassified, and the misclassification we worry about is those who are G6PD deficient and they're going to be called normal. So our estimates based on our data is roughly 3%. Deficients will be called normal based on RDT results alone.
So Marius,
next slide.
I'm going to have to ask you to go to slide 17 at this point in time, because we do want to open up to questions. I apologize for this. I know we started a little bit late.
No problem. Yes, I'll go through. Yeah, go ahead, and I'll go very quickly through the rest of the slides. Yep.
We're just going to go straight to slide 17, if that's okay. Just if you can give some summaries.
Oh, I see. Perfect. No problem. No problem, Gonzalo. Yes, please go ahead.
Is that the last one?
Yeah. That's slide 17. Oh, it's summary of the results.
Great. Thank you. This one?
Is this a slide?
No.
You want me to discuss?
There you go.
Yeah.
Okay.
Sorry about this. That we have some questions. Yeah.
No problem. No problem. And again, you can share those slides with the participants, and they can look at the other information that's in the other slides. So the bottom line is that despite the perceptions that there are risks involved with taking Primaquine, in general, most volunteers were willing to take Primaquine, and that applied both for single dose and 2 weeks radical cure treatment. And despite the other takeaway message was that perception of Primaquine risk was lower post-training, which resulted in more trainees willing to prescribe Primaquine based on G6PD test results. So this was despite quite extensive discussions about the limitations of the test. It still resulted in overall more comfort level with using these diagnostic tests for guiding treatment decisions. And despite, again, detailed discussions about hemolytic anemia, most patients perceive the risk to be lower after counseling.
Thank you so much.
So,
yeah, go ahead, sir.
You know, we can stop here. I know I'm running over time,
Yeah.
so we can maybe discuss some of the other points via question and answer.
Okay. So, and thank you. I appreciate that you actually have a very, very, very rich data set. And it's a shame to cut it short. Did want to open it up to questions. Does anybody have any questions they want to ask? Particularly thinking of the approaches taken in Brazil and some of the topics and actually the quite interesting results presented by Marius as well in Cambodia.
I just have a question for the Brazil study, something to think about. We had a number of tests with the rapid diagnostic test where the reading window changed color, but it wasn't uniform. It wasn't the entire reading window. It was basically like split in half. So half of the reading window changed the color, and half of the reading window did not change the color. So I'm just throwing the question out there: how will that be interpreted in the field?
We saw that actually this tendency of the result, the reading window of the color change only at the borders of the reading window. So it sometimes makes it difficult for the health agents to interpret, and they tend to interpret that as an intermediate or deficient result because of this. The color change is hidden under the borders of the platform. So it's something that we saw on the training only, but so far we haven't seen after the implementation of the test. At least we have not received reports of that so far. But on the training we saw that something, and only some of the agents reported to us what would happen in cases where the test is, there is a color change, but not in the middle, but rather on the side of the tests.
So we saw that quite commonly in the field. Well, when I say common, we saw it. We don't actually know how common it was because it wasn't captured until later on because we didn't realize this was happening. So that's something to think about. How will that be handled? Because I think, and Gonzalo, you may have input on this, but I think in the insert it says that those are not valid results. But probably most of these, if there's a color change from our experience, and again, it's not 100% proof because we didn't do it in a standardized fashion. But I think I think based on our data, it seems like even if it's just half of the window changes color, most of these are actually normal.
I think that's a whole topic that I think is coming up, and also from your studies and work with Brazil as well around the quality assurance, and I think Germana has something to say about that as well. I do want to open up to questions to others on the call. I have a few questions, but did anybody who's on the call have any questions?
Hi.
Hi.
So there was two highs. Maybe the male was the first one, and then we'll go on to the next one.
Women first, please.
Okay.
Wow. Okay, then I'll go first. So
I
I
hadn't
have
recognized the
a
accent. Now.
Yeah, that's Germana. Hello, everyone. So I have a question for both sides because you say you use in Brazil intermediate and deficient normal blood to do the training, and in Cambodia you say you purchase samples with different G6PD activities, and so I was wondering how do you both did it, because that's quite important, and we usually use like sample from people in the staff, but it would be nice if there was something that was a little bit more harmonized. And so I was wondering how you did it in Brazil, and how did you purchase the samples in Cambodia?
In Brazil, we actually used the recombinant G6PD controls that they recently published, I think in 2017, and they worked fine on that platform, especially with the intermediate result. That's one that causes more problem in Brazil. So we used this recombinant G6PD controls that were obtained from PET.
Okay.
Yes, we're supplying those.
Okay. Thanks.
Marriott?
Yes, for our study, I went through CareStart, and they put me in contact with the distributor, and I think we basically I think we purchased it. Again, I can pull up the details. I don't recall, but I think we purchased it from the U.S. from a distributor in the U.S. But we had, I think it was from Access Bio. They basically provided us with both deficient, normal, and intermediate controls, and we used that for the workshop training because we wanted to make sure that they can interpret at least deficient and normal using these controls. So we went through CareStart. They put us in contact with the distributor for these controls, and that's how we purchased it.
So it may be ACS controls. But it would be helpful if you could find that out.
But I can provide those details. Yeah, I can pull up those details.
Just before we wrap up, there was another question. Now from the mail.
I have three questions to Marius and some considerations from our part. The first one is that in your evaluation, Marius, you have an option of could not determine the result. Did you plan this previously, before they started, or it was an unexpected mention by the trainees? They could not determine option, because we don't have this option here.
Yes, very good question. We actually planned for this before. It was not retrospective. We basically told the trainees that, you know, you are testing male patients, so male patients, most likely they should be either deficient or normal. You should not have intermediates. But if you are in a position where you basically cannot make the call whether there's a color change, just call it unclassified or undetermined. So we will know. So if you basically don't know, you have to just literally guess, select that choice. Could not determine. So it's because we wanted to have a sense of how many tests would basically be difficult to interpret. I mean, very difficult to interpret in the field. Because again, male patients, we were thinking that, you know, if they're going to be either normal, either deficient, not much of intermediate, so maybe the color change would be a little bit easier. And we did find that to be the case. We've only had 6 cases that were not that were classified as could not determine the color. They basically couldn't know. They were undetermined whether there was a color change or not. 6 cases out of you know, all the volunteers we've tested, and that was primarily by the trainees in the field, and only one no call for the expert in the lab. But again, just among the male patients.
It's because in a real situation in the field, in which the microscopist, the professional, has to decide the treatment, for example, this type of result, I don't know if it is a good idea to test, to give this option for the trainees. Only an opinion.
Okay.
I don't know if I want to discuss this.
So thank you. I'm sorry that we've run over time just a little bit. This is Celia. I'm the one who sent the email to everyone. We would like it if you have further questions, please email me and I will distribute them so that we can get them answered. Also, please email me with future potential topics that you'd like to discuss. We want to thank everyone for participating in this. This is our first webinar for the Operational Research Community of Practice. So every one of you is pioneers on this first try, and we really appreciate everyone's contribution and engagement. So please email me with questions and future potential topics. Okay. Thank you so much.
Thank you so much, everyone.
Thank you for setting this up.
Thank you
so much for adding. Thank you.
Take care.
Bye-bye.